Hi, folks. I'm excited for our conversation today, and I want to set the stage by making a statement that I think we can all align on, and that is that there's no argument that healthcare in America is not affordable. And this affordability crisis is at its worst, ironically, when an individual or a family is in a health crisis, like you might be fighting to survive cancer and simultaneously decimating your family's financial health to pay for treatment. And the burden sometimes forces families to choose between food and medication. The debt is deepening racial disparities, destroying borrowing power, and preventing people from saving for retirement or paying for their children's higher education. And the most perverse part of this is that it can lead people to being denied care or putting off or avoiding care that they really need, and care that would be less expensive than the care they might wind up needing later if they ignore their needs today. So in today's episode, we're going to hear from a physician who has poured his heart into finding ways to prevent wasteful spending and serve as a financial advocate for his patients, saving them money, but also ensuring that they get the right care at the right time, no matter what kind of insurance they have, or even if they have no insurance at all. Now, this is not a role that physicians are ever taught or trained to do, but in a broken system designed to be unaffordable, physicians, particularly primary care physicians, may be the only ones who can protect their patients from financial harm. So with that said, let's get started. Hello, and welcome to The Pulse, the Elation Health On Demand interview miniseries discussing hot topics across primary care, health tech, and the healthcare landscape. I am your host, Dr. Sarah Pasteur, family physician and Senior Director of Primary Care Advancement at Elation Health. The topic of today's interview is physician-led financial advocacy for patients. Today's guest is my cherished friend and colleague. We're both fortunate to belong to a giant community of change makers fighting to restore American healthcare to a system for people, not for profit. But I don't know anyone who is more tireless, passionate, and innovative in this endeavor than my guest today. I'm so lucky to conspire with him and be inspired by him on a regular basis, and I'm delighted to share his wisdom with our audience today. A respected figure in healthcare, Dr. Jonathan Bushman is known for his leadership and innovative thinking. As a physician and advisor, he reshapes healthcare dynamics, emphasizing patient-centered care and modern solutions. With nearly 2 decades of experience, his insights have shaped healthcare strategies and improved care access. His dedication to advancing healthcare is evident in roles like past president of the Oklahoma Osteopathic Association. Equipped with a political science degree and recognized as Hint Health's 2023 DPC of the Year, Dr. Bushman's innovative healthcare approach stands out. He promotes direct primary care models, enhancing patient-physician relationships for better health outcomes and cost savings. By advocating for technology integration and education, he drives efficient care delivery. Dr. Bushman's efforts promote collaboration among healthcare stakeholders for effective strategies. His influence propels healthcare innovation towards patient-centered quality care for all. Welcome, friend.
Thank you so much. It's very humbling to listen to, but no better than coming from you. So it's my pleasure. As you said, cherished friend, and I consider you a cherished friend as well. We've had a lot of great experiences, honestly, in multiple parts of the country in front of different audiences. And we share the same passions and the same the same mentality about the changes needed in healthcare. So no, it's a pleasure being here, and I'm looking forward to the discussion.
Well, I've been waiting for this moment to get you on the pulse. And there's nobody I'd rather sit and talk with about topics like this. So thank you so much for joining us today. Maybe we can start with you just sharing a little bit about yourself and your practice.
Sure. I graduated residency in 2013. Went into a fee-for-service practice with the traditional employed hospital model. Did that for 5.5 years, and about the first 3 or 4 years, I grew to a very strong practice, very large patient base, and then the whittling began corporately on the various different pieces. You need to do this, you need to do this a little bit more. We're going to take away this pay, but you can get it back in the form of a bonus and a quality metric. And everybody knows this game. RVUs became, like the poker chips at the casino. Do I really own them? Do I not? I don't know. What is this worth? And will they be there at the end of the night? It was kind of demoralizing in so many ways. So about 4.5 years into it, I realized one day in my clinic that I'm sitting there thinking, in the last 4 years, I don't feel like I've grown personally or professionally, but I sure have built a lot of patience. That's the only thing I can say I've done really well, is build a lot of patience, but I don't know that I'm making a difference, and I'm a little bit scared that if I spend another 5 years in the same seat, that I'm going to wake up 10 years older than I did and be nowhere different. And I started really looking out into the world about how can I change this whole deal for me, because it wasn't just me that was suffering, it was my family that was suffering, and honestly my patients. They were becoming more and more dissatisfied. They couldn't get things done. I wasn't able to really help them because I had too many of them. And ultimately I came to the decision that the best way I could get closer to my patients was to just completely eliminate the billing side of my practice. And the reason I came to that conclusion is, once I got rid of the billing, there was no other party outside of that exam room that could shape or decide what the incentives were for care. And so I landed on the DPC model through various different experiences and connections. And I saw it in action one time, one morning, and was wholeheartedly bought in a moment's in just a moment's time. And that has held true now for over 5 years. I've been a DPC, and I tell patients all the time, I don't have an incentive for anything besides the best health for you. When you come into this clinic, you're not going to get anything besides my best for you and your best. And you don't have to worry about us pulling punches or hidden bills or anything like that. So it's very refreshing, very liberating, and quite frankly, I don't know how I could ever. I just wouldn't, honestly. I would find another career, which I've happened to do a little bit doing the benefits advising. Kind of happened to find that other career in taking that financial piece and incentive piece one step further.
Yeah, I'm with you. I would never go back either. I was similarly scarred by those terrible poker chips, and have transitioned to direct primary care. And it is magical and transformative when you get the middleman out from between you and your patient. We could do a whole nother discussion about direct primary care and why that's so magical and transformative. I think you and I could talk about that for days on end.
Mm-hmm.
But let's come back to today's topic. So, what have you seen are the most common financial barriers that prevent patients from accessing necessary healthcare services, or navigating their insurance benefits, or even if they're uninsured? Like, what do those barriers look like?
Honestly, it's just complication. It's the complication of the financial system itself. So whether you're talking insurance or benefits, the average person or patient, even very intelligent, very engaged patients, typically don't know the answer to what is your benefits plan cover? What does your insurance cover? They don't know that until they've actually gone and sought care, or gotten an EOB in the mail. That's when they first realize, like, what does this cover? They get one employee meeting if they're on an employer-sponsored plan. They get one employee meeting a year, or if they're on a Medicare supplement, they go to their advisor once a year to get their Medicare supplement. Past that, they don't think about it. They don't realize it until they have an episode of care, and that EOB lands in their face. And so that's one part, is on the benefits insurance side. And when I say insurance side, we're talking about, we're transferring financial risk. That's what that is. But we're still not purchasing healthcare. All we're doing is transferring the risk of potential healthcare costs down the road. And I would say that most people don't know their deductible on their auto insurance or their home insurance. They don't know those details either. They think about it one time when it's in front of them and they forget. So that's one thing, is it's just complicated on the front side. On the back side, when they're actually going to a facility or a practice or whatever, obviously there are federal transparency rules, but that does not mean that we actually have real transparent prices when we go to a hospital or go to a clinic system or even imaging center. Many times we don't know what those costs are. So to me, the barriers are the system itself is complicated. What is the cost? I just had a conversation prior to us getting on today with a CFO of a company that I work with. The company spends over $2 million on healthcare per year. And he recently had a procedure himself, and he said, I just got my EOB. It said the total charges were over $800, but our allowable was $260. He said, can you make sense of that for me? And I said, well, don't you triple charge everything that you guys put out for your manufacturing business? He says, no. No one would ever go for that. And I said, yeah, that's healthcare. It's designed that way to be confusing, and to provide this really fake value that a network provides by giving a discount off that billed price. It's fake. It's completely fake. But the whole industry does it. We've changed that. DPC's changed that. On the benefits side, there's a lot more direct contracting done that takes that complication and that obscurity away from the system.
Yeah, it's so interesting to think about how, like, if we compare and contrast health insurance to home insurance or auto insurance. So home insurance and auto insurance are a thing that you hope to never use. It's just sitting there in case of catastrophe. But everyone needs health care. And so, of course, you hope to never use it for a catastrophe, but you still need to use it for routine maintenance, which we don't do for our homes or our cars. And then those policies are pretty straightforward. You have a deductible, and then things are covered to a maximum after that. But with health insurance, you've got co-insurance, and you've got co-pays, and you've got prior authorizations, and you've got in-network and out-of-network. It's so complex, to your point. And of course, there are little surprises everywhere. You just never know what you're going to get. And so that's so challenging, not just for patients, but even for healthcare insiders. We don't even know. And then, of course, every policy is written a little bit differently. Even, a benefit plan within a certain payer is different from plan to plan. So the complexities abound. It strikes me that, in a normal fee-for-service type of healthcare environment, physicians barely have time to address what the healthcare issues are, much less get into these financial discussions with their patients or have time behind the scenes to advocate for their patients. So that's something that I feel like is kind of unique to the DPC space. And I'd like you to talk a little bit about why it's important for physicians, especially primary care physicians who are doing the blocking and tackling for our patients in a variety of ways, to do that kind of financial advocacy and help our patients understand, where they can sort of leverage the system in their favor or workarounds? And what practical steps can physicians take to educate their patients about these financial aspects of their healthcare?
Well, as I answer that, and a little bit before I answer that, I want to share a little conversation I had with an executive, and I will say this is a hospital executive that I had this conversation with, and asking to consider some direct contracting. And one of the responses to me was, well, patients, it shouldn't be a problem because, the prices are transparent. I mean, they're on our website. And I, without hesitation, and probably didn't think about it long enough, I said, well, have you tried to look up the prices on your website? And he says, well, no. And I said, good luck. You know what a CPT code is. You're among the less than 1% of people who know. I said, and then you'd have to know which CPT code it was to figure it out. And you're going to have multiple CPT codes per hospitalization or procedure, right? Well, that's true, but then he says, well, but patients should know what their benefits are. And I said, again, less than 1% know what their benefits are. So if you're not driving that conversation, and I'm not driving that conversation to protect our patients financially, it's not going to happen, period. And he was very uncomfortable with that, which is okay. But yeah, to answer your question, I actually, and we can talk about what patients should know or what we expect them to know or what they could do or what questions to ask. We could do that all day, but the reality of the whole situation is that's going to go nowhere. On an individual basis, maybe someone takes a little bit of more initiative and they have their own personal victories because they did, just like consumers in any other part of our industry or in any other market. But ultimately, when we are the ones guiding and directing, I personally believe it is absolutely our responsibility as physicians to take that initiative. And so primary care, specifically preventive medicine, is something that within primary care we talk about all the time. I mean, we do our annual wellness visits. We're talking about getting, colonoscopies and PSAs and pap smears and mammograms and all of these preventive things because we're trying to prevent, number one, a bad health outcome, but downstream regrets, right? I wish I'd have gotten the colonoscopy. I wish I'd have gotten that lab done. I wish I would have done these things, because when we are the ones directing care, we take that position and that responsibility very seriously. And so when I'm now outside of the quality metrics world, I'm doing that because these patients matter to me, and there's a specific and very good reason why we need to be doing prevention. That's on the health side. On the financial side, I would consider financial advocacy like the preventive medicine of financial health care, because what we're doing is we're thinking through some of the financial pieces that our patients may not understand, and we're actually guiding them without even necessarily having to educate them on that. We already know. And so when I'm going through, I mean, it doesn't matter what kind of situation clinically, if I'm going to start making orders, whether it's labs or images or procedures or diagnostics of sorts, or referrals, etc. Once you've practiced financial advocacy clinically multiple times over, it becomes part of your thinking process. And it's not that you're avoiding care because of costs. You're thinking through, and as you provide your guidance, and here's my suggestion, here's what I would recommend we do. You start thinking conservatively for the patient's benefit. And in the cases where medically that, hey, we're going to have to bypass some of this stuff, we really need to go to a more expensive procedure, or we need to get this referral, that's okay, but I'm going to make sure I put you in a place that has other people that have your financial interest in mind. So yeah, I think of the financial advocacy piece much like I do preventive medicine. And I don't have patients coming in asking for colonoscopies or asking for pap smears or asking for, they don't do that very often. That's just not, they just don't do that very often. And you're not doing your job if they're asking a lot anyway, because you should have that taken care of. But we need to lead with that. We've got to guide our patients and completely have that in mind. And I've said it before, and the truth is I regret being in the position that I was, but in many cases, when those downstream regrets would occur and a patient would tell me how much something cost. This is years ago. When a patient would tell me how much it cost and be frustrated, I would kind of throw my hands in the air. Well, that's not on me. That's between you and your insurance company. Or that's between you and the hospital. Or that's between you and my employer because I don't control the bills. Well, you know what? I do. I do control those bills. And I am responsible. And so it's just a different mentality altogether.
I'm glad you said that about how this is not about, denying care or avoiding care. I think it's estimated that something like a third of healthcare spending in the United States is just waste, fraud, waste, abuse. So there are many opportunities to curtail some of that spending just by being more mindful, not doing unnecessary duplicative testing, things like that. But I think beyond that, and certainly there is a conservative approach to, thinking through what is really necessary, and then having conversations with patients about, this is how much this is going to cost and that type of thing, when those things are knowable. But I think that you're talking to going a step further, which involves some of the direct contracting and getting discounts, things that can be made much less expensive by just having a direct financial relationship with the provider of care rather than billing insurance, which tends to be so much more expensive. And then your deductible is involved and you wind up having to pay so much more than you would have if the relationship were just between the patient and the provider. So I was wondering if you could maybe tell us, give us an example, share one of your favorite stories about how you financially advocated for one of your patients and it made a big difference for them.
So, as you know, in the direct care world, while there are data points and dollars and lots of things that you could show with graphics, the anecdotes are really thick, right? The anecdotal stories in direct care are that's our lives go. And it's like every day we have these experiences. So to narrow it down to my favorite, I'll do my best. I'll make it two people instead of just one because I can't pick a favorite. So on the clinical side, on the pharmacy side, actually, I had a Mexican American patient, had not established a green card yet. Was married to a citizen and just had not established this yet. She had CML. She was on imatinib, or Gleevec, the brand name of it. And she, due to cost reasons, they were having to acquire her imatinib from Mexico, and it was costing them $2,000 a month, and they're having to transport this, and this is a life-sustaining medication for her. I mean, a huge deal. And her husband, super sweet guy. I'd taken care of him for a while before, and he comes in just desperate. What can we do? What can we do? Is there anything? And hadn't seen the hematologist oncologist for quite some time, and so I made a quick call to my local hemonc and said, here's the situation. Do you have any issues with continuing this care? Maybe we can get in for a follow-up visit, but in the meantime, I'm going to get some medication. So I sourced from my wholesale pharmaceutical, and $270 later, I had a month's worth of imatinib for her. So I saved them about $21,000 a year on their medication. The coolest thing, and I'm getting chills thinking about it. I'll never forget it because there was the language barrier. And I tell him what I'm going to get this medication for, and I tell him it's going to be there the next day. And he's breaking up. He can't hardly even tell his wife as he's translating in Spanish to her. And you could see the emotion on their faces as he's trying to tell her and she's trying to understand this. And she's looking at me like, is this real? And, oh man, I think I lost it with them that day. But so cool. And, a little follow up to that, I told a pharmaceutical rep who I really, really admired. I mean, he was a very, very great guy. I told him this story, and as soon as I told him about how much I got it for, He's like, oh, so how much did you sell it for? Like $700, $800, $900? Like, what did you sell it for? I was like, I sold it for what I got it for. And he goes, right, but you would have said, I mean, you could have sold it for $1,000 and saved them $12,000 and you're still their hero. And I was like, it never even crossed my mind. I was like, but I guess that's why you do what you do, and that's why I do what I do. Is that terrible? Uh, but I'm like, I never even thought about that. No, no.
I mean, that's that contrast between, a healthcare system for profit versus one that's for people. And,
Hmm.
and you're doing this for people.
The second story was kind of cool too. It was a lady who had a C-section or delivery 10 years ago and did not have a tubal done at the time, but later on just decided she wanted to have a tubal done. So elective procedure, and one of the local hospitals had quoted it out between hospital anesthesia and surgeon. It was going to be about $12,500, and she was cash pay. Um, so she calls me and says, "Hey, is there any other option?" I said, "Well, I'm pretty sure your surgeon is contracted at the local surgery center, but let me give him a call, and I'll be seeing him in about an hour, so I can ask him directly." Um, Within an hour and a half, we had negotiated the whole procedure at the local surgery center for $2,500. That's a fun phone call to make. That's a really fun phone call to make to a patient and say, "Hey, I know you're looking at 12 and a half, and I can do a little bit better, but are you sure you're okay with this?" And, well, what's the amount? I said 2,500. Yeah, like, are you kidding me? Like, no.
She must have fallen out of her chair.
Yeah, yeah. Very, very cool. And again, so many anecdotes within our profession, and I'm sure if you go across the country and talk to physicians who've placed themselves in a position of financial advocacy, it's a different type of rewarding experience. Obviously, we're doing great medical care, but there's something additionally satisfying about knowing that you protect them against financial ruin or financial heartache.
Yeah, and at the same time, you're preventing that money from going to a third party that has nothing to do with improving that patient's health.
Exactly. And we talked about this through, I mean, COVID. If the one thing that COVID did to the healthcare system is it created an incredible amount of distrust. I think if there was one word to describe COVID in healthcare, is distrust, and patients learned to distrust for various different reasons. And in primary care, our patients it's so relationship based, and the best outcomes are when it's relationship based. And in my opinion, there's no way to develop a deeper, quicker trust than to financially advocate. When they know you're doing your job, but then you went above and beyond and made sure that I didn't pay something unnecessarily, man, they are patients for life.
Oh man, that's beautiful.
Yeah,
I love that.
because they know
So
you've
are
got
there, go ahead.
no, they know that you've got their back, that you're looking
Yeah,
out for them. Yeah,
for sure. It removes that transactional nature that has become so prevalent in the fee-for-service world. Um, and instead of them feeling like the healthcare system is just methodically taking money from me, you're putting it back in their hands and
hmm
helping them get healthier at the same time.
hmm
So, are there resources or programs or approaches that are most effective in supporting patients who are facing financial difficulties in accessing healthcare?
Broadly speaking, absolutely. Yeah, there's plenty of them, but it kind of depends on your it kind of depends on your locale as well. So knowing what maybe local systems have or local foundations to help with patients. Um, but there's it's not talked about enough, but there's also rules and laws that require hospitals to help with, specifically nonprofit hospitals, to help with patients in financial need if they meet the qualifications based on the federal poverty level, which is up to 400% the federal poverty level. That's a lot. I mean, that's probably 80 in most locations. That's going to be 80% of people meet those qualifications, and there's not enough advocacy from the hospital. Now, if a patient asks the hospital to help them out, the hospital's obligated to help them. But we don't see the hospitals lead with that conversation at
And
all.
people don't know that.
And they don't know that. Yeah. So that would be one piece. And the other trouble, and one of the things we strive to do, is let our patients know, if you end up in the hospital, you end up with bills, you're welcome to bring them to us. I mean, we're not responsible for them, but you're welcome to bring them to us so that we can help you understand what to do with it, or how to deal with it. But we try to be, again, proactive. But yeah, if they have problems, we ask them, bring us your EOBs. We'll help you understand it. We'll help you know what questions to ask.
Yeah, I know one DPC physician who told me a story about a patient who um, got his bill after a hospitalization, and it was, he would never be able to pay it off. He just didn't, he was retired, and there's no way he would ever have been able to pay that off. And this physician called the hospital in their little community and talked to the billing office and said, look, you're never going to get this amount of money from this guy. So let's make a deal here. And he was able to negotiate them down to a reasonable amount that was affordable for the patient, and a payment plan that he could live with,
Mm-hmm.
and relieve so much stress for that patient.
Mm-hmm.
But to your point about laws and regulations, I know that, for example, I live in Texas, and we can't dispense medications out of our clinical practices. And that's not true for you in Oklahoma and many other states. And I wish that we could make this universally true, so that physicians everywhere could really help their patients get around that pharmaceutical industry and get their patients affordable medications like you do.
Mm-hmm. I mean, you do have Mark Cuban in Texas, right?
We do.
Yeah. I've been really proud of him. He's been very vocal about the PBM industries, and what he's doing is actually available. I mean, we have local pharmacies that will do the same kind of cost plus model that he's doing, nationally. And that's one of the things that I've done, at least on a local basis. I've gone to my local pharmacies and said, hey, would you be willing to, if I send a patient your way, would you be willing to do a cost plus on their generic medications? Granted, we do dispense, and we have most of the stuff most of the time, but they're absolutely willing, because bring them our way. We'll do what we can to help them. And I mean, everyone's got a business to run. It's not like we're trying to undercut them, or especially the locals. I mean, local pharmacies, I'm going to do everything I can to keep them around. And that's a whole, my mind just is wanting to go somewhere else with that, but that's a whole nother conversation on what PBMs have done to local pharmacies. And
Mm,
we as physicians really need to be advocating for our local pharmacies as best we can, because the power within that industry and the bigs is not good.
for sure.
Say it
Now,
that
do
way.
you use GoodRx?
I use GoodRx quite a bit, yeah, but I think there can be other better things as well. But knowing what your retail prices are, if someone pays cash, is a huge deal. I mean, Walmart was the first one to come out with the $4 list, right? Well, there's still stuff on that, and they can be the quote unquote loss leaders, um, but they're not losing money on it. They're just wanting everything else to come along with it. So again, my local pharmacies, I know that they're gonna treat my patients right from a cash basis if they do it that way.
Yeah, I've even seen GoodRx prices that are lower than what your copay would be if you use your insurance.
Right. And yes, again, that's something I think in another episode or discussion would be fun to dig into, because of how those prices are all broken down, the acquisition cost, the allowable cost, what the PBM actually pays the pharmacy. It's called,
Rebates,
you talk about complication in healthcare. I think PBMs have the most games you could ever play in
for
healthcare. I mean,
sure.
we think hospitals do a lot of it, but no, the PBMs it's worse than Vegas.
Lots of sleight of hand for sure.
Mm-hmm. Mm-hmm.
So, do you have advice for other physicians who would like to do more to support their patients in this way? And do you have a call to action for policymakers?
So those are two questions. So for the physicians listening, yes, it honestly it starts as just digging in a little bit. It's calling and asking for prices, and collecting that data for yourself. Have it at your fingertips. Know when the time comes that whether it's a pharmaceutical, an image, diagnostic, even what the backside conversations look like with patients and their bills at the local hospital. And granted, depending on where you're at, you may have multiple hospitals to choose from or multiple providers to choose from, or you may be like me in the rural area where you are somewhat limited, but we still know how people practice and we ask a lot of questions. And so I can't put my patients in known harm's way financially. And so there are certain referrals I don't make. In other words, certain places I may not make referrals unless the patient just says, this is where I want to be. And so it's asking questions first and being proactive about saying, I want to understand this and it matters to me. And from at least my experience has been most of the providers either in DPC or, in fee for service that have taken that role had a personal experience. Either they became the patient, their mom or dad became the patient. Something happened where they realized what was happening on the backside of their care, and they finally took that role. So, not that I want something like that to happen to everyone before they get into it, but that tends to be what happens. On the policymaking side, there's a lot that could change. I mean, when you say policy, it makes you think government. That's just where your mind goes, is government and policy. And yes, there's things that the government can do, but I'll be honest, I don't look toward the government to make the effective change in healthcare that we're wanting or what we see as possible. I really feel like the policies will come about as the private market changes healthcare. The reason I stepped into the benefits advising space is because I realized that many times the conversations with the patients, yes, I can help here and there on meds and labs, et cetera. But on the bigger stuff, more the catastrophic, really the insurable types of risk within those plans, those decisions have already been made. There's somebody else administering all of that. Those PBMs have already been chosen. Those TPAs have already been chosen. The Blue Cross, Cigna, United, ASOs have already been chosen. And I realize, okay, there's a major influence in the spinning of healthcare that's happening without clinicians involved and without patients involved. And that's on the employer-sponsored health plans. And so I feel like it was almost a natural thing for me to step into that because I'm doing this on an individual basis. Now I'm saying, okay, rather than trying to fix one life at a time, let's try 400. Let's try 900, right? Let's try 300 at a time. Because now, getting into those conversations, I can look at those employers right in the eye, the CFOs, CEOs, whatever, and say, I know exactly why your health plan doesn't work. Let me show you. This is very simple to me. It comes as no surprise. And quite frankly, if you don't want to change your broker, there's only two things that can happen in the world of employee or employer-sponsored health plans. Either your broker changes or you change brokers. So only two options you have. So you can go back to your broker and ask them to change for you now that you've been educated on how the system works and what opportunities you may have that you didn't know about, or you just change your brokers, right? Very simple. And it's a bold statement, but it's a very simple statement. And they know that I lead with transparency, and they know that I'm going to give them the same thing that I give my patients. You're going to get advocated for every day of the week, and I'm not going to have any incentives on the backside that may cost you more money and your employees more money. So to me, it's exactly. And I say this all the time. I don't think brokers are bad people. I love many of them, and quite frankly, many of them work for someone else who's given them incentives just like I did at the hospital. So, I can't be too harsh on them because it's like somebody else is paying them, somebody else is incentivizing them. They're gonna work in the way that they've been incentivized, just like I did. And it's a beautiful thing to be autonomous as an advisor. I don't have somebody telling me what the incentives are. I can work directly with the employer, and quite frankly, I've even put myself out there as a chief medical advisor. Right? Keep your broker. You want them to do all you like them. You don't want to get rid of them. All right, keep them. But here's what it would cost for me to be in your plan, making the adjustments. I don't have to be the agent of record, but I'm the medical voice that you've never had, the actual clinical medical voice that you've never had. And quite frankly, when you can't increase your wages for your employees and your employer-sponsored health plan costs keep going up year over year, and you look around your C-suite or you look around your decision makers at your company and you have no one who understands healthcare, I have the opportunity to change that. And I don't have to be your clinical physician per se. I can be your physician advisor helping you make business decisions that benefit you and your employees. It's that simple.
Yes, yeah, that's incredible. I've had the opportunity to dabble in some of that myself in my own career, and it's really not hard. Like
It isn't.
they don't know what they don't know,
Mhm.
and these things are second nature to us, really, because we've been working inside of it for so long. And it's pretty easy to see where those struggles are. And I know other physicians that are doing this as well. And I think more physicians need to step into this space and help those employers. That is a super impactful way to begin to shift the way that all of this is being managed and delivered across the employer-sponsored health plan space. And they control most of those dollars. So this is the Lord's work that you're doing. Really, really proud of you.
I appreciate it. It's fun. I mean, it's different, in a sense too. When I'm in clinic or with a patient, um, it's as best I can say, it's altruistic. I'm really trying to help the person. It's just one person at a time. And on the benefit side, it's almost a little competitive. Well, it is competitive. It's very competitive. And the old baseball player in me and my competitiveness comes out because I realize like I'm competing against these long-standing thoughts and assumptions, and sometimes even long-standing relationships that I'm the first one to say I don't want to break relationships. That's by no means what I want to do. Um, but I want to challenge thinking. You know, I want to ask some questions. I want them to start to understand what they didn't previously know and empower them and let them take back control of their spend and take back control of their employee health. And to me, it's a challenge like no other challenge I've seen before, and it baffles me at times why it's so challenging. Um, because like you just said, it's really simple, but then again, we've seen this, we know how it works. It's simple to us, but it's just not simple to the everyday consumer and everyday employer.
You meet some skepticism, don't you?
Tons of it.
Yeah.
Of it. And so I have something I tell my employer potential clients as well, and it's very simple. I can either add value to you and I'm worth something, or I don't, and that's what I'm worth, and I'll get out of your way. Okay? Give me a chance to show you that I have value. And if I can do that, I'm worth something to you.
And what a heady experience to be able to have that kind of impact across 900 patients as opposed to one patient at a time. Yeah,
Exactly. Yeah.
that's fantastic. Well, John, thank you so much. As always, we could talk for hours about these topics,
Mhm.
and I can't thank you enough for sharing your incredible expertise with us. And it's just truly a pleasure to learn from you. And I hope you'll be back and we'll talk about more things. So, if you have questions or feedback about this content, or if you have ideas for a future episode, please don't hesitate to contact us at marketing@elationhealth.com. And thank you to all of you who tuned into our discussion today. We're so glad that you're here. To learn more about Elation Health, please visit elationhealth.com. To access our webinars and Pulse episodes, visit elationhealth.com/resources/webinars. And all other inquiries can go to marketing@elationhealth.com. Thank you.